Thank you. And I want to thank Aaron for the title of this lecture, which is, Do I Really Need My Scalpel Any Longer? So I'm Tom Serena. I'm a vascular surgeon. I practice throughout the United States. And we're going to talk about not just DebEx, but the combination of DebEx and fluorescence imaging, or the MolecuLight device. So what are the goals of debridement? Well, we know that we are going to disrupt biofilm. Probably one of the most important parts of debridement is that the biofilm will be disrupted. You're going to kill bacteria, remove devitalized tissue and non-viable tissue, reduce the host proteolytic enzymes, and remove the cells at the edge of the wound, which are senescent, no longer functioning. So we've known this for a long time. I'm a surgeon. I like to cut things. So this is something I've done with a scalpel blade and a curette for a very long period of time. Another important point in dealing with chronic wounds is that there's a certain level of bacteria in the wound that impedes wound healing. Now, this is not necessarily infection. Infection means that the surrounding tissue is also has bacteria. But in the wound bed itself, there's a lot of bacteria. How much is too much? Well, it turns out that more than 10 to the fourth colony-forming units per gram is too much bacteria. And we call that level the chronic inhibitory bacterial load, or CIBL. And that's the acronym that we use, and this is now published. So in the wound, bacteria form biofilms. Why? Because if you put bacteria in any environment and you stress the bacteria, they form a biofilm. They favor a biofilm phenotype. So about 85% of chronic wounds, diabetic foot ulcers, venous ulcers, certainly pressure ulcers, there is a biofilm present. The reason that the data shows that you need to debride the wound weekly is because you need to disrupt this biofilm. Pseudomonas and staph form this real thin microscopic layer called the extrapolymeric substance. They invite all their friends to come in. It's very resistant to any type of antiseptic or any type of chemical till now. So in the past, we had to debride this. Now, one of the other interesting things about biofilms is that they're mostly water. In fact, about 97% of a biofilm is water, and that's important for why DEBRICHEM works. All right, so methane sulfonic acid, what is it? It's a desiccating agent. It sucks up the water. So it removes water, and if I just told you that biofilms are primarily water. What DEBRICHEM does is sucks up the water, so you destroy the biofilm. And we've been saying this for a while, but when DebRic first came to me and said, it does this, I said, well, we know it does it in a lab. Alberto told me it does it in a lab, but does it do in real life, in wounds? Because sometimes things we do in labs don't correlate to what we do in patients. So because it's a desiccating agent, sometimes you'll see this carbonaceous material on top after you use it. Sometimes you see it, sometimes you don't, and that's a normal chemical reaction. There's nothing really wrong with it. The interesting thing is you only need to apply it for 60 seconds, and it's an exothermic reaction. It's warm, which I like because you know it's working, and actually the patients like it as well because, again, it seems like it's doing something. It is, because it's exothermic, it is somewhat painful, so you do need to use topical or injectable anesthetics. All right, so fluorescence imaging is the use of a violet light at 405 nanometers, and when you shine a light at that particular wavelength on a wound, the bacteria in the wound have a molecule called a porphyrin, and those porphyrins get excited when they're exposed to this light, and they re-emit their own light, which is red. Now there's a device, it's called a MolecuLight device. The device has AI in it that counts the number of pixels that come from the bacteria. So we shine the violet light on. If there's more than 10 to the fourth colony-forming units per gram, Sybil, as I mentioned earlier, then you'll see fluorescence. You'll see red fluorescence. Now, one exception, Pseudomonas does not have porphyrins. It has pyoveridines, a different molecule, really does the same thing. So it won't shine red, it'll shine sort of a halo white cyan. So you can see here, this is what it looks like. You can see that toe, and it's got that red ring around it. That is bacterial burden. That's biofilm in a diabetic foot ulcer. In diabetic foot ulcers, it tends to form a ring like that, and that's what we call the ring of fire. Now, a lot of people still culture wounds. And you remember when they taught us to culture a wound, you go this way, and then you go that way, 1 square centimeter in the middle of the wound. Well, guess what? The bacteria aren't in the middle of the wound. The bacteria of concern, those that cause invasive infections and form biofilms, live at the edge of the wound. So your swab cultures are really very, very inaccurate, and you get the wrong bacteria. So we use this device to detect biofilms, and it also will detect planktonic bacteria. But primarily in wounds, it's the biofilms we're concerned about. This is Pseudomonas, and you can see that it's a halo cyan color. And you can actually use this device to detect Pseudomonas, and you know that is the bacteria. All the rest of the bacteria are red. All right, and one of the other interesting things is that in dark-skinned individuals, it's very difficult to see bacterial load or infection. And this is one of my patients here, right there, on that dark-skinned pressure ulcer patient. I look at that and say, there's no way I would say that's infected. When you take the fluorescence image, you see that it has a large amount of red present, and this is probably 10 to the 10th bacteria. It's an enormous amount of bacteria present in this wound. You just can't see it. So your clinical signs and symptoms are not very accurate, particularly in dark-skinned individuals. Our standard cultures are not very accurate either. So we're back again. We're going to keep going. So this is my favorite case of Alberto's. We were in the clinic, and you can see that pre-treatment, it's got a lot of non-viable tissue, and the fluorescence image shows a lot of red. Now, in addition to the red that's in the wound and on that little piece of skin, you also see red on the toes. It's on the peri-wound skin. Now, I don't know what that means. We do see it a lot. It can't be good, right? It can't be good to have large amounts of bacteria right next to your open wound, and certainly that bacteria could get into the wound. So I think you may have seen, if you saw one of Hans's earlier lectures, he showed smearing the DEBRICHEM on the peri-wound skin, something I really think is important now, based on what we've seen with the MolecuLight and the amount of bacteria that forms on the peri-wound. So pre-treatment, you see that. Post-treatment, you can see it looks like I debrided with a knife. It's very clean, and it's done a very nice job. The slough is gone. It's a nice granulation bed. But you can also see that the peri-wound fluorescence is gone. And I've never seen that before. There's nothing that I've ever used that has done that. So we were really, really excited when we saw this case because I haven't seen anything do it before. In addition, you can see that almost all the fluorescence is gone after one treatment. And that's really remarkable. I will tell you that we've been using MolecuLight now for 6 or 7 years, and if you take an image and it's positive and you debride it with a scalpel blade, only about 10% of the time will the fluorescence go away. It usually takes weeks to get rid of that fluorescence when you're using a scalpel. And this is 1 week later. Looks very nice, a very nice result. One of the interesting things that we noticed was that with the use of DEBRICHEM, if you come back a month later or a week later, it still tends to be bacterial negative. And the fluorescence, there's no fluorescence in the wound when you shoot it with the MolecuLight. I don't understand that. Biofilms reform rapidly within 48 hours. You would think that a week later you would see the biofilm back. But that's not something we saw. There seems to be some persistence of the resistance to the biofilm formation. And again, we'll have to study that more, but it's a very interesting finding. Here's a venous leg ulcer, lots of drainage, very painful, and you can see that obviously that needs to be debrided, and the fluorescence image, here's our Pseudomonas. So heavily exudating wounds have lots of Pseudomonas. If you're trying to grow Pseudomonas, make the wound wet, and you'll get Pseudomonas. So these types of venous ulcers with all this drainage are going to have a lot of Pseudomonas. As expected, you'll apply the DEBRICHEM and you let it sit for 60 seconds. In this case, we use topical anesthetics. And you can see it cleaned up really nicely from a debridement standpoint, but all the Pseudomonas is gone. So it completely destroyed what was probably a mix of planktonic Pseudomonas and biofilm-based Pseudomonal. And this is going to accelerate your wound healing. Here's follow-up a week, and then a month post-operatively. Boy, it looks nice and it's beginning to heal. At this point, it would be suitable for grafting. Here's a patient who has a vasculitic ulcer, and you can see again large amounts of Pseudomonas present. Application of the DEBRICHEM, wait 60 seconds, reshoot it, and you can see the Pseudomonas is gone. And now you're seeing some of this carbonaceous material build up in the wound. That's not bad. First time I thought I would, oh my gosh, it's black. No, that's okay. And you can actually kind of work your way and work some of that out on the next visit. Or Alberta tends to let it come off on its own, which is another option for you. And then you can see 1 week and then 1 month post-op for a vasculitic ulcer. Very nice. Again, now appropriate for other advanced therapies. Here's another case, again, similar pre-treatment. Obviously, this wound needs to be debrided, and the MolecuLight image shows Pseudomonas and other bacteria are present. And there's still a little bit of red on the post, but not a whole lot. And you can see that it's cleaned up quite a bit. Not completely, but this will clean up nicely later. And you can see that about a month later, you've got nice granulation tissue in a complex wound. A post-op wound, I really like this case too. So here's a post-op wound, and it's got obviously got a lot of drainage, right, because it's macerated. So when you take an image, you see that there's a red around the edge. So this is a surgical site infection, it's post-op infection, but it's early. There's no pus draining from this. So what do? Well, you know, I was like, oh, Alberta, we better give him antibiotics. Don't need antibiotics. So we applies the DEBRICHEM 60 seconds, let it sit on the wound, and you can see it opens a little bit. There wasn't any purulent drainage in there, and the post MolecuLight image shows that we've cleaned up that bacterial presence. So early detection of a surgical site infection, that's something we're working with now with the MolecuLight folks in detecting early infection, and DEBRICHEM may play a role in its treatment. And this is just a post-op 1 week. You can see it's cleaned up nicely. The maceration's starting to go away, and it's obviously, there's no residual cellulitis. All right, so in conclusion, it's a liquid scalpel. Aaron says he's going to go home and throw all his scalpels away. And it removes both planktonic and biofilm-based bacteria. For us, the removal of the biofilm bacteria is really important. Again, 85% of chronic wounds will have a biofilm present because that's the phenotype bacteria like when they're in a stressed environment. It removes a non-viable tissue, just like sharp debridement. What I didn't show you, is I should have, is some really big wounds. You're going to show some big wounds later. Yeah, some really big wounds, and using it to remove large amounts of non-viable tissue in a big wound. And it rapidly prepares the wound bed for the next step in advanced therapy, whether that's grafting, negative pressure, any of the advanced products that you might find here in the exhibit hall. All right, that's me. You can email me if you like, and thank you very much.